Well, it's a pleasure to be providing another update on COVID-19 therapeutics. This is the September 2022 update. These are my disclosures. In today's talk, I'll be providing an update on nirmatrelvir boosted with ritonavir, as well as a brief update on where we stand with monoclonal antibodies for the prevention and treatment of COVID-19. Let's start with a discussion of nirmatrelvir and ritonavir. The EPIC high-risk study, a phase 2-3 trial conducted in individuals who were at high risk of progression to severe COVID-19, is the trial that really provided the basis for the emergency use authorization of nirmatrelvir ritonavir, also known as Paxlovid, for the treatment of outpatients with symptomatic COVID-19. The study enrolled individuals with proven SARS-CoV-2 infection, so people with positive antigen or PCR tests who had symptoms, but not more than 5 days from the onset of symptoms. Individuals had to be outpatients, and they had to have at least one risk factor for progression to severe disease, which included a whole list of potential medical comorbidities or being of older age. What the study found, as shown clearly in panel B in this figure, is that the participants in the study who received the nirmatrelvir ritonavir combination were substantially less likely to progress to require hospitalization or to die as compared to people who received placebo. Overall, there was about a 70% to 80% reduction in the risk of disease progression. This effect was seen in subgroup analyses in essentially all of the subgroups, whether people had onset of symptoms within 3 days of dosing or within 5 days, whether they were older or younger than 65 years of age, regardless of sex, regardless of body mass index, presence or absence of diabetes. There was a suggestion that people who were already seropositive for SARS-CoV-2 might have had less of an effect compared to those who were seronegative. And among those who had received or eventually did receive monoclonal antibodies for treatment of COVID-19, there was no statistically significant effect, as you can see at the bottom of the slide here. So based on these data, the current indications for use of nirmatrelvir ritonavir, at least in the United States, per the FDA's emergency use authorization, are for treatment of mild to moderate COVID-19 in non-hospitalized adults and in children aged 12 years or older who have confirmed SARS-CoV-2 infection, who are at high risk of severe COVID-19, and are within 5 days of symptom onset. Notably, this drug is not authorized for use in patients who are hospitalized for COVID-19 or for either pre or post-exposure prophylaxis. There's also a cautionary note about the use of the drug together with other agents that are metabolized by CYP3A4, of course, because ritonavir is a potent CYP3A4 inhibitor and may lead to potentially serious drug-drug interactions in those cases. And the drug needs to be dose reduced in patients with moderate renal insufficiency and is contraindicated in patients with an estimated GFR of less than 30 milliliters per minute. Now, despite all of these very impressive results, there are a number of questions that have persisted regarding the use of ritonavir boosted nirmatrelvir. These include, what is the efficacy of this agent in populations who are at standard risk of severe COVID-19, that is, those without a risk for progression to severe disease? What is the efficacy in vaccinated populations, since the clinical trial excluded people who had received a vaccine? Now, the trial really was conducted just as vaccines were beginning to be used, so that wasn't a major issue at the time. And then what about clinical relapse and virologic rebound following treatment with nirmatrelvir ritonavir? Well, to address the first question, in addition to the EPIC high-risk study, a parallel study, the EPIC SR trial, was conducted in people at average risk of progression to severe disease. There were several interim results that have been released, although not yet formally presented and not yet published. And this information is based on data released as of the middle of June of this year. The EPIC SR trial enrolled more than 1,100 participants who had confirmed SARS-CoV-2 infection, who, like the HR study, were within 5 days of symptom onset, and included two different populations, either those who were vaccinated and had at least one risk for severe disease, although subsequently the requirement for a risk factor was removed because the drug became available for those with a risk factor, as well as in unvaccinated persons. The primary outcome of the study failed to show any statistically significant difference in sustained alleviation of all symptoms for consecutive days. Now, in contrast to the HR study, where hospitalization and death were the primary endpoint, since this study was focused on a healthier population, it was anticipated that there would be no difference in hospitalizations, and so the endpoint was about symptom resolution. And they did not show a significant difference in time to symptom resolution or the proportion of people with symptom resolution as defined in that primary outcome measure. There were, however, trends and some significant differences with respect to secondary outcomes. There was a non-significant, approximately 50% reduction in the relative risk of hospitalization and death among those who received nirmatrelvir ritonavir as compared to the control group. There was also a nearly 60% relative risk reduction in hospitalization or death in the subgroup of vaccinated participants who had at least one risk factor for severe COVID-19, although this also failed to achieve statistical significance. And then more recently in this June update, a 62% decrease in COVID-related medical visits, that is either a visit to an urgent care center, to an emergency room, or actual hospitalization, was seen across all patient groups relative to placebo. So by all patient groups, meaning with or without specific risks for disease progression. And that was a statistically significant finding. In addition, there is a very large retrospective cohort study that was published recently in the New England Journal of Medicine, showing the efficacy of nirmatrelvir ritonavir in a largely vaccinated population during the Omicron surge, since most of the data in the phase 2-3 trials had been collected during the Beta and Delta surges. And this study, conducted in Israel in Clalit Health Services, used EMR data, or electronic medical record data, from members of this large Israeli healthcare organization, data collected between January and end of March of this year. Once again, the study population were those with confirmed SARS-CoV-2 infection. They had to be 40 years of age or older and had to be eligible to receive nirmatrelvir ritonavir according to criteria in place by the Israeli health authorities. And this meant that these were individuals at high risk of severe COVID-19. The primary outcome was hospitalization due to COVID-19, and the secondary outcome was death due to COVID-19. And the study examined data from nearly 110,000 patients who were included in the analysis, 4% of whom received nirmatrelvir ritonavir. About 40% were age 65 and older, and nearly 80% had either been vaccinated or had a history of COVID-19 or both. So they had some immunity to COVID-19. What the study showed was that for those over age 65, there was nearly an 85% reduction in the hazard ratio for hospitalization or due to COVID-19, and that was clearly statistically significant. However, in the younger group, those age 40 to 64, there was only a 25% reduction in the hazard ratio, and that failed to achieve statistical significance. And you can see the graphs below that table showing the cumulative hazard ratios over time. In addition, if you look at the hazard ratios for hospitalization for COVID according to immunity status, you can see that for those over age 65, there were substantial reductions in the risk of disease of hospitalization, regardless of whether there was pre-existing immunity or not. So about an 85% reduction in those who had no previous immunity, and about a 70% reduction in those who did have evidence of previous immunity. And once again, for those who were younger than age 65, there were in the group without immunity, there was a trend towards a significant, towards a substantial effect, about a 75% reduction, but this failed to achieve statistical significance and no effect seen in those with previous immunity. So this study answers some questions and poses others. The question it answers is that, yes, for those who are older and at risk for progression, there is significant protection against hospitalization for COVID, even among those who have immunity to SARS-CoV-2. But for younger people, even though they have risk factors, there didn't seem to be a benefit. That doesn't mean that the drug is not active. It means that the younger participants were at low enough risk that there wasn't really an advantage that could be demonstrated. Now, of course, this is a retrospective study, and only a small percent of all these 100,000 plus people who received, developed COVID actually were offered drug. And the question such analyses always raise is, why didn't the other people get nirmatrelvir, ritonavir, since they were eligible? And there could clearly be significant confounders that impair the overall generalizability of these findings. Now, another analysis was done by my colleagues in the General Brigham system here in Boston, Massachusetts. And what this graph shows is the incidence of SARS-CoV-2 infection by day over the course of a similar period to the Israeli study, in this case from January through the middle of May of this year. And then and you can see how at the beginning of the year there was this massive spike due to Omicron. These are really the BA1 and BA2 phases of the Omicron surge here through the middle of February. And you can see down here in orange the number of hospital admissions. And then beginning in March, there was an uptick once more in activity as BA4 and BA5 became prevalent. And you can see at this point, nirmatrelvir became available and was introduced into practice. And by the middle of May, nearly 300 people per day were being prescribed nirmatrelvir, ritonavir for treatment of outpatient SARS-CoV-2 infection. And what you may be able to see, but it's somewhat hidden in the graph here, is that the hospitalization rate remained very, very low, much lower than was seen in this earlier period, despite very high numbers of cases and this large number of prescriptions. So as some evidence for efficacy, I should say that actually at this time, nirmatrelvir, ritonavir became the second most commonly prescribed medicine for outpatients in our large hospital system. In looking at the risk ratios for hospitalization, here the dotted line is unity, so anything falling to the left of the line shows a benefit of nirmatrelvir. And you can see, once again, there were substantial benefits for participants overall. This was true for people, especially in other than the very elderly, where there may have been other mitigating circumstances, regardless of economic status, regardless of race, ethnicity. There was less of a significant effect for those who were vaccinated, but still there was a trend towards protection. And then again, for those who were immunocompromised, and a bigger effect in those who were obese compared to those who were not. Well, let's turn now to talk about the issue of relapse and virologic rebound after nirmatrelvir, ritonavir. A relapse of symptoms and or return of a positive SARS-CoV-2 antigen test has occurred in some recipients of nirmatrelvir, ritonavir. a rebound was observed in similar proportions of participants receiving the drug or placebo in the EPIC-HR study, and I'll show you those data in a moment. But there have been many anecdotal cases reported, especially on social media and in the press, and notably of some very prominent individuals who experienced rebound. But there have been no, or at least very rare, reports of severe disease complicating rebound. So why do we see rebound? There are some hypotheses. First of all, we know that protease inhibitors are reversible inhibitors, and so it's possible that after 5 days, the effect of the protease inhibitor, once you stop dosing, wears off and you see rebound. It's possible that early antiviral treatment delays the development of an immune response, although very recently at the Virology Education Symposium on Viral Infections and Inflammation, Elbing et al. Reported data showing that there was indeed evolution of an immune response even in people on nirmatrelvir ritonavir. It's possible that 5 days is not long enough, and there are studies underway currently to compare 5 days with longer dosing. And it's possible that rebound happens whether or not people are receiving nirmatrelvir ritonavir. So first, to look at one of the earliest reports of SARS-CoV-2 rebound after nirmatrelvir ritonavir. These are data from colleagues of mine, once again from Massachusetts General Hospital and Brigham and Women's Hospital. And you can see in these 7 participants here, the green bars, well, first of all, the gray columns indicate the time of treatment, and then the green bars represent the period of symptomatology. So you can see how treatment often was accompanied by resolution of symptoms, and then in 6 of these participants, symptoms recurred. And then what you can see are times when home antigen tests were positive, as shown in the purple downward arrows. All of these participants had virus sequenced, and none of them showed evidence of any mutations in the protease that might be associated with resistance to nirmatrelvir. Several did have high levels of antigen as detected by, did have high virus loads as quantified by PCR, and a few were actually culture positive. You can see participants 2 and 5, so potentially transmissible. These are the data from EPIC-HR that I mentioned a few minutes ago, looking at both the treated and placebo groups. And you can see that in the treated group, about 23 people, and in the placebo group, 17 people experienced rebound. So these are really very similar proportions of participants. No reason to believe that there's an increased risk of virologic rebound following treatment as compared to placebo. And then in a really very clever analysis, Jonathan Lee, who is a colleague of mine, looked at data collected by the ACTIV-2 ACTG A5401 study teams, pooling placebo data from a series of clinical trials that explored either different doses of bamlanivimab or the combination of amubarvimab and ramluzevimab as treatment for COVID-19. So these are just the placebo recipients. And what they found is that if you looked at the time using study day 4 as a baseline, somewhere around 4% of people had virus loads above 3 logs and a symptom score that included 4 points based on a scoring system regarding severity of symptoms after having initial improvement in their symptoms. So this is no treatment, and then 4% have symptom rebound, and 2% had a high-level rebound. And then in the secondary population, which used 8 days from symptom onset as the baseline, you can see that somewhere between 1% and 2% of people had rebound. And importantly, if you look at what were the outcomes in these individuals, here the blue dots or the blue squares represent a time where there were no symptoms, and then the red represents rebound, and the orange squares at the bottom represent the time of hospitalization, you can see that none of the people who experienced rebound progressed to hospitalization. So in the last couple of minutes, let me quickly provide an update on where we stand with the SARS-CoV-2 monoclonal antibodies. Now, of course, the epidemiology of COVID-19 is constantly changing, and where we saw the takeover of the BA.5 subvariant of Omicron during the late spring of this year, and it has now persisted throughout the summer as the predominant variant that is circulating. Other variants are beginning to emerge, although much more slowly than was the case with the BA.5. And at the present time, the BA.4.6 variant makes up about 9% of infections seen in the United States, and about 8% in northeastern United States, including where I am in Massachusetts. And the question, of course, is what is the susceptibility of this variant to the antibodies that we are currently using? So Takashita and his colleagues have been providing regular updates as letters published in the New England Journal of Medicine about the susceptibility of each variant as it emerges, both to the series of monoclonal antibodies as well as to the antiviral small molecule drugs that we're using. And this most recent update that appeared a week or two ago in the New England Journal explored susceptibility to BA.2, BA.5, and another variant that is circulating in parts of the world, BA.2.75. And what you can see is that the BA.2.75 variant is somewhat less susceptible to silgavimab and to tixagevimab compared to the ancestral strain shown at the top, but much more susceptible than to BA.5 in the case of tixagevimab. And these are the two components of Evusheld, which is used, authorized for prevention of SARS-CoV-2. And as you see on the right-hand column, nirmatrelvir remains effective against all of the variants, and bebtelovimab maintains activity against both BA.5 and BA.2.75. This slide shows data generated by David Ho's lab on the in vitro neutralization activity of several different monoclonals against a range of the Omicron subvariants. So obviously the variants are shown along the bottom here. To orient you, what's shown here it's the IC50, but in this case, the way the y-axis is displayed, the higher the IC50, the lower on the y-axis. So this is really the reciprocal of the IC50, and so the most active agents have IC50s showing here up at the top, meaning their very low concentrations are effective and the resistance is at the bottom. And so what you can see here is that for tixagevimab, which is one of the components of Evusheld, there's no activity against BA.4 or 5, and there's no activity against BA.4.6. And similarly for silgavimab, the other component of Evusheld, while there is activity against BA.4 and BA.5, there is no activity against BA.4.6. So Evusheld is not expected to have activity against this new circulating virus, although to date, again, it's only about 9 or 10% of isolates in most of the United States. Bebtelovimab, shown here in red, retains activity all of these variants. And here all the way on the right, you can see how the combination of the two antibodies against BA.4.6 has no activity, although it does retain some activity against 4 and 5 themselves because silgavimab remains active, and the BRII antibodies have substantially reduced activity against essentially all of the Omicron variants. So thank you very much for your attention, and I look forward to the discussion.